Hi, everyone, and welcome to the next session on vaccine development. I'm François Fenter. I'm a physician based in Johannesburg at the University of the Witwatersrand. So I think for all of us, the silver lining on this horror show of a pandemic is the unbelievable speed at which we've seen vaccines being developed. And I think for many of us, people like me who were peripherally involved in HIV vaccine development, watching how quickly our basic scientists and our manufacturers and our developers and our researchers have brought these things to the fore is astonishing. I think what's also been a silver lining is how much we've been able to build vaccine literacy amongst the clinician and the general community. So I'm looking really forward to the next couple of talks. I think the last session was phenomenal. Our first, and I'll be co-chairing this with Kathryn Stephenson, who will introduce herself in just a moment. But our first speaker on the is going to be Penny Moore. Penny is a basic scientist and has actually been catapulted into becoming a bit of a household name in the last little while in South Africa, attached to the National Health Laboratory Services. Penny is going to be speaking to us about becoming resistant to current vaccines and the implications for vaccine development. In terms of her biography, she's a senior scientist attached to South Africa's National Institute for Laboratory Services, which is a major epidemiological and disease control, infectious disease control role. She also has a whole range of other hats and appellations that are attached to Wits University and to the University of KwaZulu-Natal. She obtained her PhD in virology at the University of London in 2003. And I'm not going to labor her accomplishments, but her research has revolved around HIV neutralizing antibodies and the interplay with the evolving virus. And I think she's brought this whole research focus onto SARS-CoV-2. Penny's unfortunately not able to join us for the Q&A session at the end of this, but I think we're all looking forward to hearing what she has to say. Over to you, Penny.
Thank you for the opportunity to speak to you today. My talk is entitled, Will SARS-CoV-2 Become Resistant to the Current Vaccines? Implications for Vaccine Development, though it's possible that the answer to this has become clearer in the last few days. So I'll leave you to judge that for yourself. So we all know from many studies now that SARS-CoV-2 infected individuals develop neutralizing antibodies and that these can persist for many months. Neutralizing antibodies are also considered the primary correlate of protection against reinfection for most vaccines, and this includes SARS-CoV-2. But it's important to note that most of the vaccines that have been made thus far have been designed on the original Wuhan 1, or in some cases D614G strain, and that most of the assessments that have been made thus far have been based also on these two strains. SARS-CoV-2 monoclonal antibodies are also being pursued as therapeutics, and so there's great interest in these types of antibodies. But in the backdrop to this, one of the issues that has really come to the fore in the last few weeks is that SARS-CoV-2 spike is mutating. So the SARS-CoV-2 spike has really always been mutating. Mutations occur regularly during the viral replicative cycle, and they can be seeded through superspreader events, or they can be selected for. Most of the changes that occur during natural replication do not confer a selective advantage to the virus, and they do not end up replacing pre-existing lineages. But this is not always the case. And in fact, we've already seen one clear example where a mutation that has emerged in SARS-CoV-2 has given the virus a clear selective advantage and has resulted in global replacement. And that's the emergence of the D614G mutant. This mutation, which arose some months ago, has now replaced essentially all the previously circulating viruses and now dominates global sequences. And this can be seen here in this image from a very elegant paper from Betty Korber and colleagues. The issue of variants of concern, which the name for variants of concern is obvious, is because these variants, these mutants that may come to dominate, can have several impacts on the virus that have public health implications. These mutations or suites of mutations in some cases may result in increased disease severity, and some of these reports have come out of the UK in recent weeks. They may result in the virus becoming much more transmissible, and there's several examples of that. And more recently, the focus has been on the possibility that these variants of concern may evade the immune response. And that's really going to be the focus of my talk for much of the next few slides. So 3 major variants of concern have been identified based initially on where they were first described. There is the 501YV1 variant or lineage, otherwise known as B117. There's the 501YV2 or B.1.351, and then there's the 501V3. 501YV1 was first identified in the UK, V2 in South Africa, and V3 or P1 as it's otherwise known, identified first in Brazil. And these maps here from the Pangolin new variant report show very clearly that these variants have now started spreading across the world. The dark green here shows community transmission and the light green shows imported transmission. But you can see that these variants are no longer limited to the countries in which they were first described. They have also been shown to have the mutations have been shown to have many different impacts on the virus. The variant that was first described in the UK has been clearly shown here to have increased transmissibility. And more recent reports suggest that the 501YV1 is also associated with increased disease severity. In the case of 501YV2, which I'm going to speak about much more in this talk, there's some evidence, though it's not entirely clear, of enhanced transmissibility and increased evidence, which I'll show you in this talk and which has been described elsewhere, of immune evasion. In the case of P1, also some evidence of immune evasion, and I'll come back to that. But I think what's important to note here is that there is some degree, at least, of evidence emerging of descriptions of convergent evolution, in the sense that all of these 3 variants of concern all have an N501Y mutation, which is the particular mutation that has been associated with both enhanced transmissibility and perhaps disease severity. Our interest in new variants that are emerging in SARS-CoV-2 really began with the detection of the 501YV2 lineage in South Africa. And this graph here shows you the emergence and subsequent dominance, really, of 501YV2. This is a paper from Tulio D'Oliveira and colleagues. And in yellow here at the end, you can see the bar chart show you the dominance of the 501YV2 variant or lineage in South Africa. And you can see clearly that by the end of November, that lineage was responsible for almost all new infections in South Africa. And now this continues to be the case. Sequencing efforts in South Africa suggest that in excess of 90 and perhaps 95% of new infections are caused by the 501YV2 lineage in South Africa. And of course, as I mentioned, it's no longer limited to South Africa. The 501YV2 lineage is characterized by multiple mutations, 9 mutations just in the spike. And I'm going to focus on the spike largely, as I mentioned, because it is the target of SARS-CoV-2 vaccine design and is the most frequently targeted, in fact, the only target of neutralizing antibodies in SARS-CoV-2. The mutations that characterize 501YV2 are really limited to 2 areas, and that immediately gives you a clue that these are immune evasion mutations. Up here at the top, so this here is the SARS-CoV-2 spike, a model of the SARS-CoV-2 spike. And up here at the top in yellow is the receptor binding domain. This is the part of the spike that interacts with the ACE2 receptor. It's also a dominant target for neutralizing antibodies, as I'll show you on the next few slides. And there are 3 mutations within this region, 501, which I've already mentioned, but also mutations at positions 417 and 484. The other cluster of mutations that define 501YV2 are located within the N-terminal domain, and that's this area shown here in cyan. And you can see that there's several mutations in that region, positions 18, 80, 215, 246, and also a 3 amino acid deletion at positions 242 and through to 244. The clustering of these mutations, with the exception of this mutation that sits down here at position 701, as I mentioned, is indicative of immune escape. Whenever you see clustering of mutations together in a 3-dimensional space, this is of concern to virologists. But the main reason that we are concerned about these clusters of mutations is that both the RBD and the NTD are the major targets of the SARS-CoV-2 neutralizing antibody response. This is particularly true of the RBD, and the neutralizing response is dominated by RBD antibodies. There are many antibodies to other regions of the spike, but when you think particularly about the neutralizing antibody response, it's dominated by RBD antibodies. And in fact, most MAB antibodies, monoclonal antibody epitopes, overlap with the ACE2 binding site. And I'm going to speak much more about the class 1 monoclonal antibodies and the class 2 monoclonal antibodies in the next few slides. The N-terminal domain is perhaps somewhat less frequently a target of neutralizing antibodies, but certainly there are many examples in the literature of monoclonal antibodies that have been isolated to this region. And these include 4A8, which again, I will speak about in the next couple of slides. So the way we approach the question of whether these clusters of mutations in 501YB2 are associated with immune evasion is by using a pseudovirus neutralization assay. This assay uses 293 T cells that overexpress ACE2 as a target cell line. These cells were very kindly provided by Mike Farzan. And we used three variants. We used the variant that was originally circulating in South Africa, which is called the wild type, which has just the 614G mutation. We also constructed, given the huge interest in the receptor binding domain as a target of neutralizing antibody, we also constructed an RBD triple mutant. And this mutant here contains only the mutations of positions 417, 484, and 501. And then we also constructed the full 501YB2 variant, which contains all the mutations that I showed you on the previous slide. So all three of these were used in pseudovirus neutralization assays, and they're the basis of the data that I'll be showing you next. We began by assessing the sensitivity of 501YB2 to monoclonal antibodies. It's a nice, clean way of assessing particular sites. We started with the class 1 monoclonal antibodies, and structural analyses and modeling have indicated that these monoclonal antibodies are heavily dependent on the site at position 417, which, as I've already mentioned, is one of the sites that is mutated in 501YB2. To understand whether these monoclonal antibodies, these class 1 monoclonal antibodies, were impacted in the new, whether these monoclonal antibodies were still capable of neutralizing 501YB2, we performed both ELISA and neutralization assays. So we selected 3 representative monoclonal antibodies shown up here at the top, and we ran them in ELISA, that's the top panel, and neutralization assays in the bottom panel. The key's down at the bottom, but if you look first at the ELISA data, the black lines indicate the binding of these monoclonal antibodies to the wild type, D614G. And down here at the bottom, you can see the binding of these monoclonal antibodies, or the lack of binding, in fact, to 501YB2. So you can see binding of all 3 monoclonal antibodies is completely knocked out. Down here at the bottom, you can see the same for neutralization. Again, in black is the neutralization of the wild type. And in red is 501YB2. And down here at the bottom in yellow is the triple mutant that contains only the RBD mutations. And you can see that in both 501YB2 and the RBD triple mutant, there is no neutralization whatsoever by class 1 monoclonal antibodies. This is the same set of data for the class 2 monoclonal antibodies. These monoclonal antibodies are heavily dependent on the position at 484. This is the same experiment using 3 representative class 2 monoclonal antibodies. Again, ELISA up here at the top, and you can see that there's no longer any binding whatsoever to 501YB2. And down here at the bottom is neutralization data showing, again, the same thing, fairly potent neutralization, in some cases very potent neutralization of the D614G, the original variant that was circulating in South Africa. But you can see that there's no longer neutralization of either the RBD triple mutant or the 501YB2. We also looked at an NTD-directed monoclonal antibody. This is, I mentioned 4A8 on my introductory slides. An analysis of several of the NTD-directed monoclonal antibodies shows that they're heavily dependent on this N5 loop supersite shown here, as well as that position 246, which is mutated in 501YB2. You can see that when you extend this, this is a model using 4A8, but when you extend this to many other monoclonal antibodies targeting the NTD, you can see that all of them are dependent on, to some degree, on the N5 loop supersite. In 501YB2, there's substantial remodeling of the NTD domain from an antigenic perspective. You can see here in 501YB2 that the N5 loop is shifted substantially. And there's also a clash here that results from the mutation at position 246 in 501YB2. And this would suggest that, NTD-directed monoclonal antibodies may no longer be able to recognize 501YB2. And indeed, when we perform ELISA and neutralization assays, we see that 4A8 is no longer able to bind to 501YB2 nor to neutralize. So altogether, the monoclonal antibody data that I've shown you shows that 501YB2 is completely resistant to 3 classes of therapeutically relevant monoclonal antibodies. They're important to point out that there are a few other monoclonal antibodies that are likely to be unaffected by these mutations that are therapeutically relevant. So up to now, I've been focusing on neutralization by monoclonal antibodies. Perhaps of more relevance from a public health perspective is the capacity of convalescent plasma from people previously infected with the original variant to be able to neutralize the 501YB2. And that's the next question we asked. We selected 44 donor plasma or sera that were obtained from people previously infected with the D614G variant, which was the dominant variant in South Africa. We very deliberately selected sera with a wide range of titers. In gray here, you can see, this is a logarithmic scale. In gray here, you can see high titer individuals with titers in excess of 1 in 400. Down here at the bottom, you can see that half of the sera we chose had lower titers, somewhere between 1 in 50 and 1 in 400. And the limit of detection for this assay is 1 in 20. So this is the neutralization capacity against the original variant. What happens when we test against the mutants? When we test against the RBD-only pseudovirus, so this contains only 3 mutations, you can see a 5-fold reduction in mean titer if you compare the 614G variant to the triple variant. And perhaps more striking, 27% of donors are no longer able to neutralize the pseudovirus that contains just these 3 mutations. That effect is even more pronounced when you test neutralization of these plasma against 501YB2, which contains the full suite of mutations. Here we see a 13-fold reduction in mean titer against 501YB2, and 48% of donors no longer show any neutralization whatsoever. Important also to point out that this is very much a titer-dependent effect. So if you look in the light gray, you can see that individuals who started with a very high titer against 614G generally retain some activity against 501YB2, whereas individuals down here with titers somewhere between 100 and 400 lose much of their activity against 501YB2. And very important to point out that this is probably the most relevant from a sort of a reinfection point of view, because most individuals who become infected with SARS-CoV-2 show titers in the lower range rather than these individuals up here who are hospitalized folks and have much higher titers. So there's clear evidence, I think, from our data and from other studies that show that the South African variant does exhibit substantial levels of immune escape from neutralizing antibodies. But I think what's probably even more striking is the fact that this is not a unique escape pathway for the South African variant. The South African variant 501YB2 shares major RBD mutations with P1, which is the variant first described in Brazil. Both of these contain mutations at 4 and 7. It's a slightly different mutation at 4 and 7, but mutations at 4 and 7, and 484 as well as 501. And what's perhaps even more striking is that even in the 501YB1 variant, which was first described in the UK, at low levels for now, people are also detecting the 484 mutation. So I think that speaks to the extremely strong pressure on the virus to escape from neutralizing antibodies, and the fact that most people have a very, very similar and focused response to SARS-CoV-2 infection, which makes it in some ways much easier for the viruses across the world to converge on the same escape mutation. So what does this all mean for vaccines? Much of what I've shown you, everything I've shown you so far is monoclonal antibody data and convalescent plasma. But what happens for vaccines? Here I'm showing you published data investigating the effect of sera obtained from vaccinees, either from Moderna or Pfizer, the two mRNA platforms, and asking how sensitive both the variant detected in the UK, defined here as UK Delta 8, and 501YV2, defined here as SA Delta 9, are to antibodies in people who received the Moderna and the Pfizer vaccines. So you can see here in black is the sensitivity of the original variants to sera from Moderna and Pfizer. There's a slight decrease, somewhere between around about twofold for the sera to the UK variant, 1.8-fold for Moderna and twofold for Pfizer. But as you can see from the substantially bigger drops, there's a much more pronounced effect against the South African variant, 8-fold for Moderna and nearly 7-fold for Pfizer. The same is true, and this is data in a preprint led by Sheba Mahdi. This is data from our lab investigating the impact of the 501YV2 variant on vaccinee sera from samples from the AstraZeneca trial that was conducted in South Africa. These are the same constructs that I've showed you in previous slides. And you can see that there's a range of titers here against the original variant. Tested against the RBD-only variant, you can see substantially lower titers. And against 501YV2, nearly 78% of vaccinees no longer show any activity against 501YV2. So really dramatic drop-offs against 501YV2. This is supported by evidence now from very recent evidence now from 3 vaccine trials that were conducted in South Africa. This is the Johnson & Johnson trial over here, Novavax, and the AstraZeneca data. The AstraZeneca data comes from a very small trial that was not particularly powered to pick up efficacy against the new variant, but nonetheless is instructive. When you look at efficacy of all of these 3 vaccines in the US, the UK, and Brazil, you can see that efficacy is fairly high, somewhere between 70 and 90%. However, if you look at efficacy specifically within South Africa, you can see a dramatic drop-off. Both the Johnson & Johnson vaccines and the Novavax vaccines decline in efficacy to somewhere around 50 to 60%. And the AstraZeneca vaccine shows very low efficacy against South African strains. And the reason that these trials are able to pick these up is that these trials in South Africa happen to be performed at exactly the moment that the new variant was starting to dominate in South Africa. This means that the investigators were able to assess the breakthrough infections by sequencing them, and were able to show that in excess of 90% of breakthrough infections in all 3 trials were 501YV2, further evidence of reduced efficacy against these particular variants. So I think the data is very suggestive that the lower vaccine efficacy observed in South Africa is likely due to the dominance of 501YV2. However, very important to point out that what is less clear is the efficacy of these vaccines against in preventing severe illness in people, even those infected with 501YV2. The data that we've heard about so far from Johnson & Johnson indicates that this vaccine still retains its ability to protect from severe infection, but we don't know anything about the ability of the Novavax or AstraZeneca trials to prevent severe illness. And of course, from a public health perspective, preventing severe illness is the #1 priority. So that is something that needs a lot of further study to understand whether this is true, and if so, what the mechanism is for preventing severe illness in people who become infected. So in conclusion, I think that the data I've shown you shows very clearly that the 501YV2 lineage exhibits complete escape from 3 classes of therapeutically relevant monoclonal antibodies. In South Africa, we're unlikely to receive those monoclonal antibodies anytime soon, but I've already shown you that the 501YV2 lineage or variant is no longer limited to South Africa. 501YV2 also shows substantial or complete escape from neutralizing antibodies in COVID-19 convalescent plasma. And that has serious implications for the next waves of virus that come through. What I didn't show you is data that we have that shows that a significant proportion of RBD binding antibodies still remain reactive against 501YV2. And that's an important finding because that does suggest that together with cellular immunity, these RBD binding antibodies, which may be mediating FC effector functions, for example, may account for the retention of the protection from disease in trials, despite the fact that there's lower activity of neutralizing antibodies. Overall, I think these data highlight the prospect of reinfection with antigenically distinct variants. And in fact, in South Africa, we're already seeing that occurring, and does provide a mechanism for the reduced efficacy of current spike-based vaccines that I showed you in the last slide. So where do these variants come from? I think the selection, the convergent evolution towards mutations that confer neutralization escape suggests that ongoing transmission and some level of seropositivity, in some places incredibly high. For example, in South Africa, we have regions where there's incredibly high levels of population seropositivity. And this likely selects for neutralization resistant variants. I think an unknown question that many of us are scrambling to answer is, how will the immune system see these new variants? Will the titers against the new variant be as high as against the old variant? And will there be cross-reactivity in people who are infected with the new variants? Will their plasma be better able to recognize not only the new variant, but also the old variant? In terms of how this data and similar data impacts on vaccine design, many of the major vaccine developers are already scrambling to incorporate new variants in their platforms. A major question here will be whether vaccination, again with vaccines that incorporate these new variants, will result in some level of cross-reactivity. And if not, this may present a short-term solution. It's certain, I think, that SARS-CoV-2 will continue to mutate. And the issue is whether the incorporation of these new variants may result in vaccines that are able to confer some level of cross-reactivity, or whether we're looking at a situation similar to that of flu vaccines, where we may need to replace the inserts of vaccines more frequently than we had hoped. Clearly, there are many lineages of SARS-CoV-2 emerging globally, and often these have convergent evolution, again, a focused immune system resulting in a focused escape pathway. And tracking these will continue to be critical for public health. And with that, I will end. I'd like to thank particularly Kirk, who led the studies in our lab of convalescent plasma and monoclonal antibodies, but many people in our lab who really worked through the Christmas break in South Africa after the 501YV2 variant was identified, and worked hard to understand what the phenotypic significance of this was. Thank you to our collaborators at the South African National Blood Service, the University of Pretoria, University of KwaZulu-Natal, and Wits University, and the 501YV2 consortium of South African scientists chaired by Drs. Hanekom and Dolabera. Also like to thank our funders, largely the South African Medical Research Council, who's funded most of this research, and our wonderful lab here who works incredibly hard to support these studies. Thank you.
Thank you to Dr. Moore for sharing that amazing talk with us. My name is Dr. Kathryn Stephenson. I'm an infectious diseases physician and a researcher. I work out of Harvard Medical School, and Beth is your Deaconess, so it's a pleasure to have everybody join us today. I am going to introduce our next speaker, Dr. Benjamin Larimer. He's coming to us from the University of Alabama and Birmingham. So he is received his PhD from the University of Missouri and trained as a postdoctoral fellow here in Boston at Massachusetts General Hospital. And he is currently an assistant professor in the Department of Radiology and an associate scientist at the University of Alabama. He has multiple wonderful accolades, including he is a recipient of the NIH Director's New Innovator Award and the NIH Pathway to Independence Award. So thank you, Dr. Larimer, and now to you.
Thank you for the introduction. I'm very excited to talk to you guys today about antibody testing and its role post-vaccination in determining the level and duration of immunity. Before we get started, I do have a few disclosures that are shown here. So when we talk about the role of antibody response and humoral immunity in terms of coronaviruses, it's important to understand how the body responds to exposure to coronaviruses. And what has been determined previously is that antibody production is pretty ubiquitous and occurs in greater than 90% of people. And this has been confirmed for SARS-CoV-2 in the Iceland serology study, which was a very extensive study that showed about 91% seroconversion among 1,200 infected patients. This antibody production is a means of protection, and some cross-reactivity occurs from coronavirus to coronavirus, although that appears to be more transient in nature. Antibody protection, despite the possibility for creating antibody-dependent enhancement, has generally been shown to be protective in cases of coronaviruses. And so the antibody production is mostly going to be productive in terms of immunity. And in coronavirus, for SARS-CoV-2, general responses include rapid maturation across IgM, IgG, and IgA isotypes. And these antibodies are produced for two reasons. The first is neutralization of viral infection, and the second is FC-mediated clearance of infected cells. And infection generally results, obviously, in protection from viral infection, but it also, in terms of non-exposed patients, there are reports now of some neutralization activity among both adults and children as well. So a strong role for antibody production in terms of viral protection. When it comes to detecting these antibodies, most antibody tests involve using either the spike protein, the whole spike protein, a portion of the spike protein called the receptor binding domain, or the nucleocapsid protein. The spike protein is the more dominant protein that's used in the antibody tests. The first spike protein SARS-CoV-2 tests were described by the Kramer group. They made a heterotrimeric fusion of the spike protein that was stable and able to be produced at high levels. And that has been used quite extensively. The other protein that is used in antibody tests is the nucleocapsid protein. This is actually the most abundant protein of the virus. However, it is encapsulated inside of the virus, and so it's only exposed during infection and cell death. All of these antibodies are predominantly measured using enzyme-linked immunosorbent assays, or ELISAs. However, lateral flow assays are also developed and are gaining in prominence and serve a complementary role that we'll discuss later. When we talk about antibody production during the course of disease, the first thing to note is that antibody production correlates with disease severity. So more severe disease produces higher levels of antibodies. However, mild disease often has higher ratios of spike to nucleocapsid protein, which is expected given the fact that nucleocapsid proteins require cell death, and more severe death or more severe disease results in more cell death. IgM and IgAs are produced robustly regardless of the severity of disease, but IgGs are produced at slightly lower levels in severe disease, and the production of IgG takes longer in non-surviving patients. And so there are slight differences in antibody production based on the severity of the disease, but overall, a pretty robust antibody response. When we talk about the duration of these antibody responses, there have been conflicting reports on how long antibody duration lasts. Most of the, or some of the early reports brought up that antibody duration may not be long, and this is probably due to the fact that antibodies do decline slightly over the first 1 to 3 months, and IgA and IgM antibodies decline more quickly than IgG antibodies. However, recent reports have shown that antibody levels remain relatively steady through months 3 through 9. And this all supports findings that were seen in SARS-CoV-1, where antibody levels remain steady for 1 to 3 years following infection. And so overall, the duration of antibodies appears to be pretty steady in terms of infection. The reason for the production of these antibodies is to protect against viral infection. And one of the main ways that antibodies can protect against viral infection is through neutralization of the virus. And these antibodies block the ability of SARS-CoV-2 to infect cells and replicate. Neutralization can be reported in a number of different ways. The most relevant way is through a live virus infection, actually using the live virus. However, there have been pseudovirus infection assays that have been developed, and even assays to look at the disruption between the receptor binding domain and the ACE2 protein. There are strong correlations between each of these three assays, and there are also correlations between antibody production and virus neutralization. So correlations between antibody production and the blockade of ACE2 binding, and as well a correlation between ACE2 blocking and viral neutralization. And these neutralizing antibodies also persist for months, just like the total antibodies that are measured. And so overall, antibodies are a strong component of protection against subsequent reinfection. And this mirrors what was seen decades ago with challenge studies done with the 229E coronavirus, which led to complete resistance to reinfection up to a year later and a blockage of viral shedding as well. So up until now, we've talked mostly about antibody responses to infection, but we're all focused on what are the antibody responses to vaccines. And obviously, there are some differences between infection and vaccines. Namely, the first is that the vaccine is going to occur in a different site than infection. Infection is going to occur in the lungs and mucosal tissues, whereas vaccination is going to occur in the intramuscular space. The immunogen is different between these two as well. Most of the vaccines are using the spike protein, whereas infection is going to be a combination of spike protein, nucleocapsid protein, and other non-structural proteins as well that are produced during infection. And then finally, the duration of antigen exposure is going to be different. Infection is going to expose antigens for a longer period of time than vaccination, although depending on the vaccination, the antigen exposure time will be different. And there's also some vaccinations that have multiple exposures, which is also different. So all of this put together means that there are unknowns in terms of how the antibody response will be different from vaccination and infection. But what is known is that all vaccines that are being distributed now enhance both antibody production and virus neutralization in the short term, and that these antibody levels generally correlate with virus neutralization. So there are similarities in that antibody production generally is going to correlate with protection against the virus. So if we start to go into the individual trials, we first look at the Pfizer-BioNTech vaccine. We can see that before immunization, antibody levels are generally low, and the kinetics of antibody response increase over time with significant differences by day 22 and a sort of a peak plateau being reached about 28 days post vaccination, and that these levels correlate pretty well with the seroconverted patients who are infected. And this occurs across all age groups and dosing that were tested. Moderna, the Moderna vaccine is very similar to the Pfizer vaccine, whereby by 15 days you see a significant increase in antibody production, and it sort of maxes out at around 4 to 5 weeks, and viral levels or antibody levels correlate well with viral neutralization assays, and they also correlate well with the amount of antibodies that are produced from convalescent serum samples. Moving on to AstraZeneca, you see more of the same. Antibodies increasing relatively rapidly, following the same kinetic pattern, and also matching the seroconverted convalescent plasma samples. Johnson & Johnson has a slightly different dosing structure and reporting structure, but still antibody production is robust. It occurs, we don't have the 14-day, but by 28 days we see high levels of antibody production across almost all the age groups. There is a slight difference in the older age group, but in general, high levels of antibody production as well. Sputnik V, no time course, but robust antibody production, significantly higher than the placebo group across all age groups as well. The Sinopharm vaccine does have kinetic data. We see the same kinetic pattern as we see with the other vaccines. It's independent of the dosing as well. And finally, the Sinovac vaccine, also a more limited kinetic profile, but we see increases in antibody production across all treatment groups. Some slight dependencies on the amount of vaccine given, but overall, the general trend is that antibody response occurs relatively quickly following vaccination. It's robust and it correlates with protection from a neutralization of viral infection. However, one of the remaining questions is how long do antibodies last? If you remember back, the duration of antibodies that are produced following infection are quite stable and correlate very well with neutralization across almost all patients. And fortunately for us, we have some new data. It's only from the Moderna trial. It's from their 100 microgram dose group in 34 volunteers. And what we see is similar stability in the terms of antibody levels that were detected and the correlation with neutralization. Now, this of course is only one of the vaccine trials. There's no other reports published as of right now. However, given the similarities in antibody response across these vaccines, it could easily be hypothesized that there will be similar levels of durability across all of the vaccines. In order to test this going forward, we need to think about what are the best antibody tests and what are the proper uses for these antibody tests in terms of monitoring antibody response. And the most widely used tests are ELISAs, and there are several common and widely used commercial assays. They have been analyzed individually and compared head-to-head. I'm showing data from the Oxford National SARS-CoV-2 Serology Assay Evaluation Group. And their head-to-head comparison of many of these tests showed that all of them are highly accurate. They have sensitivities that range from 93% to 99% and specificities from 98.9 to 99.9%. And in fact, the group reported that by slightly altering some of the parameters, all of the tests can produce 98% sensitivity and specificity. And so these ELISA tests are very robust. They've been used to gather the data that we've seen for both infection and monitoring the vaccines, and will continue to be used going forward for these. But they are laboratory-based tests, and there are some limitations to laboratory-based tests. The logistics of testing large amounts of samples we've seen in terms of the molecular tests can be challenging, and it also the availability can be limited in lower resourced areas or rural areas. And so there needs to be alternatives as well. And one of the alternatives are lateral flow assays. And lateral flow assays offer the ability to measure antibody levels at the point of care. And so you have greater flexibility in terms of who gets tested and where they get tested. However, the lateral flow assays historically for SARS-CoV-2 have had a checkered history. And the early lateral flow assays, there were some that received EUAs that ended up not having the necessary specificity and sensitivity that were required. The FDA has gone back and reviewed these and removed some of the EUAs, and so the current EUAs have demonstrated higher sensitivity and specificity. But even still, the literature on these is a little bit variable. I'm showing data from Johns Hopkins group, though, that show that there are lateral flow assays that can perform equivalently with ELISA tests, but the general consensus remains the ELISA in terms of accuracy is going to be higher than the lateral flow assays, but the lateral flow assays have sufficient performance characteristics to be used in specific point of care settings. In addition to these formats, there are also alternative antibody detection methods that are being investigated. One of them has a FDA emergency use authorization. It's a neutralization test from GenScript called CPAS. What it does is measure the disruption of the ACE2 RBD interaction. And it is the closest correlate to live virus or pseudovirus neutralization assays that is available without needing a BSL 3 or 4 laboratory. So it has potential to really be useful in terms of providing a good surrogate for neutralization assays. Our group and other groups are also looking at using combinatorial chemistry to map more specifically the epitopes that patients' antibodies are binding to, with the goal, you can see in the data on the right, being to identify public epitope domains that can be used to differentiate antibodies specific for SARS-CoV-2 from those from similar coronaviruses, and with the goal being to increase the specificity of antibody tests and decrease the number of false positives as well. So with all of that being said, the role of antibody tests going forward, I see 3 areas where antibody detection is going to be very helpful. The first is assessing community immunity prevalence. As we progress in delivering more vaccines and trying to control outbreaks, understanding the level of immunity from a community perspective is going to help to not only be able to respond to outbreaks but also to understand where new outbreaks may be likely to occur, and to dedicate resources to help curb that through increased vaccinations and information. The second role is we kind of talked about that a lot of these vaccine trials have published great data and they are very effective, but the information we have is limited in terms of how long these vaccinations are effective for. And so antibody testing will provide a very valuable resource in monitoring the duration of immunity, and then also specific groups that weren't tested in clinical trials that will be receiving the vaccine, understanding how the efficacy it plays out in those groups and at an individual level as more and more people are vaccinated. The final area where antibody detection can be helpful is a little bit more abstract, but it's in the ability to provide a tangible measurement to individual patients on the efficacy of their vaccine. We all know that there is skepticism in some groups around vaccination, and the goal should be to help overcome that skepticism. And one of the ways that antibody testing can help is to give people a tangible proof that the vaccine is working to protect them and hopefully provide them an incentive to get vaccinated. So with that, I'd like to thank the organizers for the ability to talk to you guys today, and I'm happy to answer any questions during the live Q&A. Thank you.
Thank you so much, Benjamin, for that talk. We've got so many questions in the chat, so keep them coming. Our next speaker is Eyal Leshem, who is going to speak to us about the real-world impact of vaccine rollout. Eyal is the director of the Center for Travel Medicine and Tropical Diseases at the Sheba Medical Center in Israel. He is a guest researcher at the viral gastroenteritis team at the United States CDC and Prevention in Atlanta, and a consultant to the World Health Organization. He's also a clinical associate professor in internal medicine and infectious diseases at the Sackler School of Medicine in the Tel Aviv University. He has led and co-authored over 90 articles and book chapters, and received his medical degree from the Israel Institute of Technology after completing a residency in internal medicine and a fellowship in infectious diseases at the Sheba Medical Center. In 2014, he graduated from his training as an epidemic intelligence officer at the CDC, and during his training, he investigated multiple outbreaks, including acute gastroenteritis, enterovirus D68, fungal meningitis, and MERS coronavirus. After graduating from EIS, he worked as a medical epidemiologist in the viral gastroenteritis team. His work focused on diarrheal disease surveillance, rotavirus vaccine impact, and viral disease outbreak investigation. And he continues to participate in CDC and WHO-led surveillance and evaluation projects assessing vaccine impact and effectiveness in a whole range of countries. His ongoing projects include every known vaccine by the sounds of it, including the evaluation of the SARS-CoV-2 vaccine, HPV vaccines, rotavirus vaccine, dengue virus, Zika virus, malaria, and travel-associated infectious diseases. He sounds like he's exactly this kind of person who's going to tell us about the real-world impact about vaccines. Over to you, Eyal.
Thank you for having me, and I'll dedicate the next 20 minutes to discuss Israel's experience in COVID-19 rollout, the rollout of the COVID-19 vaccine, and some early evidence of COVID-19 vaccine impact in Israel. So first, a little bit background on Israel demographics. Israel is a nation of 9.3 million citizens. 6.8 are Jewish and 1.9 are Arab Israelis. A birth cohort is about 176,000. We have the highest total fertility of the OECD. We're number one with 3.01 children per woman. We have one of the lowest healthcare expenditure of the GDP, of the national GDP, only 7.4%, which means we don't put a lot of money into healthcare. And despite these two facts, we have one of the highest life expectancies in the entire world. We're number 7 with life expectancy of 83 years. So overall, good health indices in Israel and a very young population. A little bit about Israel's healthcare system. And Israel has a national health insurance law, which means every legal resident is entitled to full medical care, the most advanced treatment at a very low co-payment of several US dollars a month. Medical coverage is universal and it's not dependent if you're employed, unemployed, where you live, or whether or not you're paying taxes. Everyone gets healthcare. And there are four public sector healthcare funds that cover all residents, and they are all with a very long history of treating communities in Israel, moved from traditional medicine to full digital electronic medical record and online, which is the rule now. Israel's immunization program is also a national program with a long history of maternal child services, very high coverage rates for children. Israel ranks one of the highest with 98% coverage for DTP3 in 2018. So overall, a good trust in the universal country immunization program. And these are the kind of the starting point of the COVID-19 outbreak, during which we had 3 major waves, one in March that resulted a long lockdown of several weeks, second in September around about the Jewish New Year holidays, where we had a peak of 8,000 patients, and the third we are undergoing now, and we have just came out of another 1 month lockdown that unfortunately did not result in a substantial reduction in cases. We're still seeing about 7,000 to 8,000 cases a day, with a total of 650,000 patients, confirmed patients since the beginning, out of a population of 9 million, and by now we reached 5,000 deaths. The vaccine rollout was on December 19 of 2020, where the Prime Minister Netanyahu was the first to receive the Pfizer vaccine in our medical center, Sheba Medical Center. You can see the Prime Minister receiving his international immunization card from the CEO of my medical center. And this was a good communication strategy to show all the citizens that we trust vaccine safety and efficacy. He was the first to be vaccinated. It was communicated all over the media. Israel came out with a prioritization scheme, which divided the population into tiers. We started with elderly persons aged over 60, persons who work at healthcare, and persons with severe immune compromising. But quite rapidly, within 3 weeks, we moved on to all risk groups and high-risk exposure, like teachers and first responders. The third tier, about 2 weeks ago, we started with persons over 50 and also high school children that need to take the matriculation. And we are now released the vaccines to all citizens aged over 16 years old, except those that were previously infected with COVID. So everyone in Israel now is entitled to get the COVID vaccine. I will pause now for 2 minutes to show a little bit a short clip about the vaccine rollout in Israel.
As millions continue to battle the coronavirus around the globe, Israel is on its way to becoming a vaccination nation. As of January 10th, 2 million Israelis have already been vaccinated, including 70% of Israelis over 60. In fact, medical personnel are delivering shots so quickly that additional vaccines from Pfizer and Moderna are on their way to Israel to ensure that the government is able to meet its goal of vaccinating all Israelis who want to be vaccinated by the end of March. Israel, a small country of 9 million, is hoping to become the first country in the world to complete a nationwide vaccine campaign. Here's how vaccines are making their way from cargo airplanes into the arms of Israelis. The vaccine arrive in Israel at Ben Gurion Airport, are then loaded onto trucks and delivered to Israel's main logistics center, Teva Sala.
Once the vaccines arrive from the airport, we load them into these low temperature freezers, they're roughly at -70 degrees. These vaccines are going to be taken within a matter of a few minutes to our designated chilled area. The Pfizer vaccine come in a tray with 195 vials. So what we did is we planned smaller packages with a small amount of vials that can reach smaller vaccination stations.
I'm almost 30 years at the company, and this is one of the most emotional events. So for us, as I mentioned, it's a national mission.
From there, the vaccines are delivered to HMO providers throughout the country and prepared for defrosting. Healthcare in Israel is universal, which means that all Israelis are eligible to eventually receive the vaccine. And we're about to show you how the magic happens. Come on.
We're going to start with filling out a standard form that's delivered to us from our Ministry of Health about your health history and about if you've been sick in the past week or so. This is our database, and this database is the one database that the entire Israeli population is on. Okay. This is Whoop, the nurse, who's going to get the basic information, make sure the right patient with the right form is here, and vaccinate.
That's it. Okay, the hard part is over, and now I just have to wait 15 minutes, make sure I'm feeling okay, and then we're done. Like many other countries, Israel is currently battling one of its most serious COVID waves since the crisis started. The good news is, thanks to advanced measures taken by Israel to obtain the vaccine and a rigorous nationwide vaccination campaign, an end to this mass epidemic may be in sight.
So moving on to summarize what you've seen in the clip, we have had a very solid, robust logistic system of moving the vaccines from the national repository to the hands of the all residents that are insured in healthcare funds, which is summarized in this slide, which made the logistics very easy in Israel. And we know many other nations have had challenges with the logistics of the vaccine. So Israel is willing, of course, to share its experience and the way we overcame these challenges. So where we are now, what you're seeing here is a slide from that compares nations with the number of daily doses administered of the vaccine. And really this line with two peaks, the dark green line with two peaks represents Israel, where you can see we had a peak of 1.5 or 2 doses per 100 citizens provided by 7-day average, which for the most time since the vaccine rollout began was the highest rates in the whole world. And this allowed us to arrive to the highest number of vaccine doses administered per 100 population compared with all other nations. So by today, we are at a very good condition compared with most other nations. What you're seeing here is that Israel has given more than 60 doses per 100 persons in the entire nation, of course, focusing on the at-risk population. So what is the current status? By yesterday, there were 3 million persons in Israel, a third of the population that received the first dose, and 1.8 received already, of these 3.4, also received their second dose and are fully vaccinated. And what you're seeing on the right was the average daily doses per thousands per week. So you're seeing we were able to give somewhere between 70 to 170,000 doses every day, all week since we began, and that's a very impressive pace of vaccination. The coverage rates in the population of persons that are over 60 years of age is 84%. So if you add 3 to 4 more % of this population that had previous infections, we almost reach 90% coverage. And in persons over 50 years of age, 79%. So we're seeing very good coverage of at-risk population so far. And as I mentioned earlier, it's these characteristics of Israel's healthcare system, the universal coverage, the logistics, the electronic media, the electronic medical file, and the strong community-based immunization system that allowed Israel to reach such high pace of vaccination and get a very good coverage of the population at risk. Now let's discuss some data of the vaccine impact. And the first study that was released on medRxiv, so pre-proof, not yet peer-reviewed, by a group from Weizmann Institute led by Ran Segal. Really what they did was compared several populations and show the incidence of vaccine condition, of COVID conditions compared with vaccination of this population. In this figure, which is a little bit complicated, I will walk you through it. What we're seeing on the bottom is the percentage vaccinated with first dose in light yellow and with second dose in orange of persons of the 100%. And on the right side, you're seeing the proportion that received first and second dose from persons over 60. So the light blue and dark blue are persons over 60, and light yellow and orange are persons under 60. And what you're seeing above the x-axis is a time axis, you're seeing numbers of cases. So what you can see is for new positive cases, new hospitalized, and new severe cases, you're seeing the yellow line kind of flattens about 2 weeks after the lockdown was initiated, but then starts to rise up. For overall cases, these are persons under 60-year-old, 0 to 59. While the blue line, once lockdown is implemented, it starts to drop, but it doesn't flatten and doesn't start to rise. So what this tells us is once persons over 60 have a high coverage rate, we continue to see declines in disease, although in the entire population, disease starts to rise again. So we are definitely seeing a vaccine impact here. When this is translated to a table, compared with the 14, 21, and 28 days back, you see the comparison of persons under 60-year-old. You're seeing a reduction, but then 28 days after the beginning of the lockdown, we're seeing an increase. While for persons over 60-year-old, we're seeing consistent reductions in positive cases, in severe cases, and in hospitalized cases. So all these tell us that there is an impact of the vaccine in the population aged over 60-year-old, where the vaccine was introduced and got high coverage. This slide looked in a more ecologic ways and compared cities that had a high coverage rate, which are depicted in green, with cities that have a low coverage rate that are depicted in red bordeaux. And on the left, the early vaccinated cities, you can see that in persons that are over 60, the green, there is a decline because of the high coverage that continues after the lockdown is released. While in this population, again, the persons under 60, 0 to 59, they are most of them not vaccinated, and we're seeing the increase. This holds both for new positive cases, panel A, for new hospitalizations, and for new severe cases. So a decline for persons over 60. And when they compared with late vaccinated cities, because some cities have an ultra-Orthodox population or Arab population where the vaccine coverage rates were lower and later. These populations were more hesitant about taking the COVID vaccine. We're seeing that the declines in the persons over 60 are similar to those in the entire population, and the declines in severe cases and hospitalizations, while they happen later and they are of lower magnitude compared with the younger persons. So again, similar data in a tabular form. You're seeing the new cases in the early cities versus the late cities, and you see that the early cities show a decline in persons over 60-year-old that is consistent, that is the green row. Persons over 60, consistent declines when we continue for 14, 21, and 28 days back, while young cases we're seeing lower declines, and the early cities have rapid declines compared with the late cities. Now, what I showed you before were ecologic evidence. There are some effectiveness data that are being released to the common media, one of them by one of the largest health funds, which is called Maccabi Health Services. This was released 4 days ago. And what they described is the number of COVID cases in fully vaccinated. So they have 254 COVID positives in 416,000 that received 2 doses and are 7 days after the second dose, which translates to 0.06% positivity. They compare this to 778,000 that are not vaccinated, where they have 12,940 cases, so 1.7% positivity. You're seeing the rate in fully vaccinated is much lower than the rate in unvaccinated. And if you do a rate ratio, you see what is similar to 96% rate reduction in fully vaccinated compared with unvaccinated. And I want to point out two things. Those that are fully vaccinated are mostly aged over 60 years old, and we are talking mostly UK strain circulation throughout January. So another slide are similar data released by the Ministry of Health, and it's the number of cases and deaths, cases by severity and death, by age group and in a person's age. And all these people that are shown here have had their positivity documented more than 7 days after the second dose. These are data for end of January. So from 740,000 persons over 60 years old, there are 531 cases positive for COVID. That's on the right row, which translates to 0.07%. But if you look at these 531 cases, 480 are so mild, they only had a positive case, a positive test. They were not hospitalized. Only a handful are hospitalized, and from those hospitalized, 16 are severe, 5 are critical, and only 3 died. For those that were infected more than 7 days after the second dose, not many, very low percentage, and very low severe cases and deaths. If you look at the same strata, those that are fully vaccinated but younger in age, 16 to 15, 9-year-old, you see 387,000 persons, only 258 positive cases, and of those, only 1 severe and 2 critical cases. So very high protection in these 387,000 patients. So in conclusion, we have high coverage in Israel of population at risk, but we need to focus on the special populations, on the Arab population and ultra-Orthodox to try and increase vaccine coverage there. UK variant was predominant in January, and we still saw good evidence of vaccine effectiveness. We're now seeing increase in South Africa variant, and we look to see if this holds. Substantial declines in severe disease in persons that has received their second dose more than 7 days ago. And we are all doing some effectiveness analysis underway, but preliminary evidence show good effectiveness even 15 days after the first dose. And I would like to thank you again for the opportunity to present, and we'll take questions during the Q&A session. Thank you.
Thank you, Dr. Leshem. That was a wonderful talk. Let me move to introduce our next speaker, Dr. Kirk Prutzman, who is speaking to us from the Food and Drug Administration here in the US. Dr. Prutzman is a team leader and a primary reviewer in the Office of Vaccines Research and Review in the Center for Biologics Evaluation, which is at the FDA. He's been there since 2008. He received his BS from State University of New York, that's Bachelor's in Science, and his PhD from the University of North Carolina. So Dr. Prutzman recently has been very involved in the review of COVID-19 vaccines, the ones we were just speaking about today, that have been granted emergency use authorization. And before COVID-19, his work was focused on Zika viruses and Zika virus vaccines. He's a member of a WHO working group. So definitely an expert in developing vaccines and improving them for pandemics. Thank you, Dr. Prutzman. I'll turn to you.
Good morning, good afternoon, and good evening to everyone. Thank you for having me to give this talk today. I'm here to talk about a US FDA perspective on determining efficacy for COVID-19 vaccines. So a brief outline of my talk today. I'm going to talk about the clinical development pathways for COVID-19 vaccines, licensure pathways, approaches to make unapproved vaccines available. And in the US, we're using the emergency use authorization pathway. And then finally, I'll conclude with some efficacy considerations for a BLA, for efficacy in children for a COVID-19 vaccine, and for efficacy against asymptomatic infection of COVID-19. So this is just a brief overview of the recent emerging and re-emerging infectious diseases that we've seen over the past 10, 11 years. And as you can see, about every 2 to 5 years, we're seeing a new emerging or re-emerging infectious disease pop up. Starting in 2009, we saw H1N1, we've had MERS, Ebola, Zika, and now, of course, we're looking at SARS coronavirus 2 or COVID-19. So I expect in the next 2 to 5 years, we'll probably see something else pop up. So vaccines against emerging infectious disease, even though there is an increased urgency to see a treatment or a vaccine against an emerging infectious disease, the development path follows the same paradigm as other preventative vaccines. That is, there's no change in evidentiary criteria and data necessary to demonstrate effectiveness, safety, manufacturing consistency. For an IND or for a BLA or for an EUA for the COVID-19 vaccine, we would expect sponsors to generate data, preclinical data for CMC and toxicology. We would expect clinical data on efficacy and safety, stability data on the product, facilities information, and manufacturing consistency data. A bit unique to COVID or SARS-CoV-2 vaccines is we expect before you go into humans that you present data on your Th1, T helper 2, T helper 1, T helper 2 response balance before you go into humans. This is a brief generic overview of the regulatory framework to make a vaccine available to the public. There is the licensure pathways, which would include traditional approval, accelerated approval, and animal rule approval. The animal rule approval doesn't really apply to COVID-19 vaccines. Then under the IND, which is the investigational new drug, we can make unapproved vaccines available to humans or to the public through the expanded access pathway. And then finally, under IND also, we can make unapproved products available through the emergency use authorization pathway. This is to make unapproved products available in response to a public emergency. And this is, as I said previously, the pathway that we're using to make COVID-19 vaccines available to the public in the United States. This is an overall clinical development for vaccines approval slide, or what it looks like, the development slide. I'm sure many of you in attendance at this conference have seen this type of slide in one form or another. What that is, in the early phases of development, you go through your research and development, you generate preclinical data, at which point, if it looks safe enough to go into humans, you come into the FDA with an IND, and you go through your phases of development, phase 1, phase 2, and phase 3. If that data looks sufficient, that is, it is safe and effective, you'll submit a BLA application, and upon review, if it looks acceptable, you will be licensed to market your vaccine, at which point you'll go and do phase 4. And as I said previously, a BLA approval would consider pathways such as traditional approval, accelerated approval, or animal rule approval. The IND, which starts at phase 1, we have the ability to make vaccines available through the expanded access. And we also have the ability to make a vaccine available to the public through the emergency use authorization, or EUA. For a COVID-19 vaccine, we are looking at data that is generated primarily in phase 3 when we make our decision for granting an emergency use authorization for a COVID-19 vaccine. So demonstration of safety and effectiveness of preventive vaccines. For effectiveness, all indications must be supported by substantial evidence of effectiveness. This means demonstration of effectiveness is based on adequate and well-controlled clinical studies using a product that is standardized to its identity, its strength, quality, purity, and dosage form. For a safety-based consideration, we would consider the characteristics of the vaccine, any safety signals or theoretic safety signals, the target population or the intended use, and the seriousness of disease of the target for prevention. Regarding COVID-19 vaccines and some key considerations that we're considering, similarly, vaccine approval is going to be based on adequate and well-controlled studies demonstrating safety and effectiveness. For COVID-19 vaccine licensure, that would be based on the demonstration of clinical benefit from disease endpoint efficacy studies or studies that show an effect on a surrogate marker, for example, an immune response, reasonably likely to predict clinical benefit. It is important to note that while that second bullet point is a potential avenue, there has not been an established surrogate marker for COVID-19. So right now we will not be licensing on a surrogate marker. And it's also important to note that regulatory review of each COVID-19 vaccine will be data-driven and the licensure pathways may differ. So I'm going to spend a lot of time discussing our expectations for an emergency use authorization because that is the primary, in fact, right now, the only avenue we've used to make vaccines available to the public in the United States. So for an emergency use authorization, the first thing that is necessary is that the Secretary must declare an emergency threat for potential for a public emergency that affects or has significant potential to affect the national security or the health and security of the United States citizens. In spring of 2020, our Secretary, Alex Azar, made this declaration. Therefore, the emergency use authorization pathway was made available for the FDA to use as a way to make COVID-19 vaccines available to the public. The criteria for us to issue an EUA, the agent referred to in the EUA declaration must cause a serious or life-threatening disease or condition. I think clearly COVID-19 fits that criteria. The medical product, in this case the vaccine, must be effective to prevent, diagnose, or treat a serious life-threatening condition. And COVID-19 vaccines clearly are made to prevent disease. The known and potential benefits of the product outweigh the known and potential risks of the product. That's clearly a review decision. But upon a good safety and efficacy review, this fits the criteria. And also, there can be no adequate, approved, or available alternative product for diagnosing, preventing, or treating the disease or condition. Currently, there are no licensed COVID-19 vaccines. The only FDA-approved product for COVID-19 is remdesivir, which is actually just for the treatment, not for prevention. And there are additional products that have an EUA from the FDA, but not approval. And of course, as been in the news, as you well know, there are a couple vaccines that have been authorized under EUA to be used in the United States. That does not mean that other vaccines cannot come in for EUA. And in fact, we encourage more vaccines to be developed and potentially to be made available through the EUA avenue. So considerations for emergency use authorization. In the United States, when a vaccine has been authorized under an EUA, informed consent is not required. To the extent practicable, recipients should be informed of the EUA and all the known potential benefits and risks of the vaccine, and if there's an option, to use available alternatives. Finally, we expect that the product is manufactured in compliance with good manufacturing procedures. Specific EUA expectations for COVID-19 vaccines. This was discussed in an October 22, 2020 advisory committee meeting called VRBPAC meeting, and was subsequently published in an FDA guidance titled The Emergency Use Authorization for Vaccines to Prevent COVID-19. Both the meeting summary, as well as I think the recording and the guidance are available online if anybody wants to read them. We have said through these mechanisms that a vaccine needs, or a sponsor needs to generate data to demonstrate manufacturing quality and consistency. There needs to be clear and compelling safety and efficacy data to support a favorable benefit risk of the vaccine when rapidly deployed for administration to millions of individuals, including healthy people. And importantly, even after an emergency use authorization has been granted, a sponsor needs to further evaluate vaccine safety and effectiveness, including through ongoing clinical trials, maybe through active and passive safety monitoring, and potentially observational studies. Some specific expectations for COVID-19 for clinical data for an EUA. We expect that efficacy data from at least one well-designed phase 3 trial demonstrating protection against SARS coronavirus 2 infection or disease, point estimate of at least 50% versus a placebo comparator, and the appropriate alpha adjusted confidence interval lower bound greater than 30%. Safety data must be captured from throughout the clinical development to evaluate reactogenicity, serious adverse events, and adverse events of special interest. This safety data should include a high proportion of phase 3 study subjects followed for at least 1 month after completion of the full vaccine regimen. And there must be sufficient cases of severe COVID-19 disease for us to assess signals of enhanced disease and potentially preliminary evidence from protection against severe disease. So additional COVID-19 expectations for an EUA from clinical data. What is occurring, we're finding, is that sponsors are conducting an interim analysis of their ongoing phase 3 studies. And what we've tried to communicate is that the planned case-driven interim analysis and associated data could support an EUA, but these analyses should include a median follow-up duration of at least 2 months after completion of the full vaccination series. The reasons for this expectation of a 2-month median follow-up is it will allow time for potentially immune-mediated adverse reactions to be evaluated, if they exist. It ensures that the vaccine efficacy is assessed during a time when the adaptive or memory immune responses, rather than the innate responses, are mediating protection. And it may allow for early assessment of waning protection and signals of enhanced disease. So for a COVID-19 vaccine expectations of an EUA for further evaluation, issuance of an EUA of a COVID-19 vaccine is contingent upon the ability to conduct further vaccine evaluation. So this means that when you come in for an EUA, and if you're granted an EUA, we still expect you to follow your patients for safety, or your subjects for safety and efficacy. That would mean that there would be active follow-up of vaccine recipients under the EUA. There might be passive monitoring of clinically significant adverse reactions using established reporting mechanisms, for example, the VAERS or the Vaccine Adverse Event Reporting System. There could be observational studies, and we strongly encourage the continuation of blinded, placebo-controlled follow-up in ongoing trials for as long as feasible, and strategies to handle the loss of follow-up. Importantly, the FDA does not consider the issuance of an EUA for a COVID-19 vaccine to necessitate immediate unblinding of ongoing clinical trials. So trial participants, we understand, may choose to withdraw from follow-up for any reason, including to receive a vaccine made available under the EUA. We would hope that that sponsors would still be able to follow these subjects for as long as possible. So the issuance of an EUA of a COVID-19 vaccine, we will specify conditions of use in which the benefit risk has been determined to be favorable based on our review of the available data. This would include the populations to be included in an EUA, conditions for the vaccine to be distributed and administered, and requirements for safety monitoring and reporting of adverse events. This will provide information to the vaccine recipients, I should say an EUA is required to provide information to the vaccine recipients and healthcare providers by way of prescribing information and fact sheets. This information should be would include that it is investigational in nature, any known and potential benefits and risks, and any available alternatives if the subject refuses vaccination. So now, these are the FDA expectations for efficacy analyses for a BLA or a biologics licensing application. And as you can see from this slide, the efficacy data we're expecting for a BLA is the same as we're expecting for an EUA. That is, for efficacy, there should be a point estimate of 50% or greater versus a placebo comparator, and the appropriately alpha adjusted confidence interval lower bound greater than 30%. The difference is that we're expecting more data to come in rather than just the interim analysis that might come in from an EUA. So the follow-up study participants should be continued as long as feasible, ideally for at least 1 or 2 years, to assess the duration of protection and the potential for vaccine-associated enhanced respiratory disease as the immune responses to the vaccines wane. So the goalposts are very similar, if not exactly the same, but we expect there to be more data when you come in for a BLA. So additional efficacy considerations for analysis of COVID-19 vaccines in children. There are 3 potential endpoints you could consider in designing and conducting a study. There could be a clinical disease endpoint consideration that would be protection against symptomatic and severe COVID-19 in children. However, we understand that the disease is much less prevalent in children, and we also understand that this disease endpoint may not be feasible to study. Another pathway, as discussed previously, is that you might consider looking at an immune response endpoint, for example, a correlate of protection. This would be a scientifically well-established immunologic marker to predict protection that can be reliably measured by a validated assay. However, this correlate of protection, as I stated earlier, has not been established for a COVID-19 vaccine. So currently, this endpoint study is not available for sponsors. Finally, we are considering demonstration of equivalent immune response to an age group with a demonstrated clinical efficacy. So for example, if your vaccine has shown clinical efficacy in, say, subjects 18 to 25 years of age, we might consider demonstrating an immune response that is measured in a validated assay in children younger than 18 to be consistent with the immune response where you've generated data of clinical efficacy in another age group. So in other words, we may allow an immunobridging study to be done. Clearly, this is a work in progress and an evolving process, and we encourage sponsors to speak to the agency before designing and starting these studies. Finally, some additional efficacy analysis in COVID-19 vaccine, efficacy against asymptomatic disease. This is definitely a very complicated process because for an indication to be included in a label, there must be potential benefit for the vaccine, for the vaccinee, or persons in contact with the vaccinee. It's unclear right now that protection against asymptomatic disease is beneficial at all to the vaccinee. Rather, it's more beneficial to persons who around the vaccinee who may acquire the disease from an asymptomatic person. So we need to show that there's benefit potentially for persons in contact with the vaccinee, and that's very difficult to show. So some things that we're considering, you may consider a study where clinical disease endpoint in persons in contact with the vaccinee is measured. However, we recognize that that is a very difficult endpoint and actually very confounded and may not be feasible. Another thing that might be considered is protection from infection or from viral shedding. This might include an endpoint of routine testing against antibodies raised against non-vaccine antigens, for example, the nucleocapsid protein, or routine testing for viral shedding, for example, a nasal swab net. Importantly, just like with the immunobridging into children, these endpoints and design of all the relevant studies will require further discussion with the agency. And I think I'm going to bring that point, I want to bring that point home as a conclusion that all of these studies, no matter where you are in development, if you want to come into the FDA, please start discussing your studies early with the FDA before you go into phase 1 and all throughout development so that we are all on the same page with what your final endpoints would look like. And finally, I'll just end with some acknowledgments. Dr. Gruber is our office director. Dr. Fink is our division director. And most of these slides were made by them and presented in other forms. And then finally, Dr. Roberts, Dr. Nyack, Dr. Agnew-Holtram, and Dr. Sepkowski contributed to this presentation. And I thank you for your time.
Thank you, Dr. Prutzman. That was an amazing talk, as were all the other talks today. So thank you from both myself and Dr. Venter for this. I thought that, well, first I should say there's a lot of questions that have come in from the chat and from the audience, and we definitely want to get to as many of those as we can, so I figure we'll just jump into it. The first question I wanted to ask came from one of our participants, audience members, and it was a question I think that is best directed to you, Dr. Prutzman, just to follow on from your talk. So it actually ties together from earlier talk as well. So if new variants need to be incorporated into currently existing vaccines, does each new iteration of the vaccine need to undergo clinical trial testing from scratch, or is there anything from original trials that could still apply? So we're still having some trouble hearing you. I don't know, can others hear you?
Oh, sorry. Can you hear me now?
Yes, thank you.
Okay, sorry about that. So adding variants or a new vaccine for the new variant, this is something that is being discussed a lot in the agency, and hopefully there'll be some new guidance that comes out soon with this. But of course, there is a need to start looking at this, and what model we're sort of considering here is similar to flu, where you would have essentially like a strain change. Now, there's a lot of experience with flu, so we know a lot about the vaccine platforms. In the United States, we've only authorized 2 platforms. Those are the 2 mRNA from Moderna and Pfizer. We hope to have some others that are coming in soon, but we don't have a lot of experience with these platforms. So we're looking at models where you would show some type of efficacy, maybe in animals, and maybe some type of immunogenicity in humans. And of course, we'd be interested in knowing some type of safety. So we're not, right now, we're not at a straight strain change. In other words, change your vaccine and start administering it. But we're also not looking at a full-scale, long-term clinical efficacy study where you'd have to show protection against disease. So hopefully, you know, in the coming weeks and months, there'll be more coming out from the FDA with this.
Thank you. All right, so let me turn now to follow up with Dr. Leshem. There was a number of different questions actually about, sort of commending the Israeli response, but then following that to say, you know, who is covered by these vaccines and who isn't. So in particular, if maybe you could share Israel's strategy for offering vaccines to Palestinians, for example.
Well, this is more of a policy than an actual healthcare or public health question. So as a doctor, as a human being, I hope that vaccines are offered to our Palestinian neighbors as soon as possible. However, from what I know, the Palestinian Authority, which is autonomous in terms of healthcare, had purchased the Russian Gamaleya Sputnik vaccine, enough doses to cover the entire population. The Israeli government did offer or did deliver several thousand doses of vaccines to cover Palestinian healthcare workers. So generally speaking, what's called the Palestinian Authority is autonomous in terms of healthcare, but of course, this doesn't refer to Arab Israelis who are full citizen of Israel and entitled to full healthcare, same as Jews and any other nationality living in Israel.
Thank you. Really difficult questions. And actually later I want to open up to the group to actually kind of talk a little bit about nationalism in general, as each of our countries are taking different approaches and have different claims to different vaccines. We have many audience members who are quite international and are not always benefiting from some of the vaccines that we've been talking about today. So now I want to turn a little bit back down to some of the basic science and turn to Dr. Larimer. There were a couple of questions that came in about antibodies, and one of them had to do with antibody responses in people who've been exposed to SARS-CoV-2 before, and how we can interpret them or use them to determine if they should be vaccinated. So I was wondering, what kind of work do you know has been done with pre-vaccination antibody testing?
Yeah, so I know that in some of the initial phase 1 and phase 2 trials, they did identify patients who had elevated levels of antibodies prior to administration of the vaccine. And after one dose, it was very similar to those patients who received 2 doses. Now, right now, it appears that receiving both doses of the vaccine is sort of the safest course of action. But I think that at least from an antibody perspective, there is evidence that pre-exposure to SARS-CoV-2 plus 1 dose of the vaccine at least elevates antibodies to a level similar to 2 doses of the vaccine.
Thanks. Actually, I had a follow-up to that, but for Dr. Leshem, because I think I heard you say that as part of the Israeli program, individuals who had COVID before were not prioritized. So can you tell me about the rationale for that decision and how that's played out?
Yeah, so initially when the prioritization scheme took place, there weren't enough evidence to show that a vaccine dose, a Pfizer vaccine dose, after having been infected with SARS-CoV-2 will provide additional protection. Even the evidence now are more on the serologic increase, that response that we're seeing in previously infected and then vaccinated person, rather than actual clinical evidence for the utility. But we do know there's experience in at least other nationalities or other nations are giving a full vaccine course to persons that were previously vaccinated. We're not experiencing any safety issues. So we think it's at least safe to provide 1 dose. We are doing that in healthcare workers of Sheba Medical Center. And as I said, we're seeing a robust serologic response to those that previously infected, now then vaccinated.
Okay, that's so interesting, because here in the US, we've been kind of agnostic as to whether someone's been infected or not. We have rough guidelines, like if you've been infected fairly recently, but if you were infected, say 4 or 5 months ago, you're prioritized along with everyone else for the 2-dose regimen of the mRNAs. It's actually it's sort of interesting. It's come up in some of the clinical trials that I've been running for COVID vaccines, and it was one of the questions from the audience about how we can use serologic testing to distinguish between those who've been naturally infected and then those who've been vaccinated. So maybe Dr. Larimer, you could jump in on that.
Sure. I think the simplest explanation would be a nucleocapsid-based serological test is going to be more informative, is going to inform on infection versus a spike protein-based serology test to inform on vaccination. And so the absence of nucleocapsid antibodies would be indicative of vaccine-induced immunity versus the presence of them would be indicative that you have been exposed to the virus.
Could you just remind our audience why that is the case and what that has to do with the way the vaccines are made?
Sure. So the vaccines are made against the spike protein. They're not made against the nucleocapsid protein. And so your immune system is only going to generate antibodies against the nucleocapsid after infection and lysis of the cells that are being infected by the virus. And so you can even see this in the case of mild versus severe infections. Those with mild disease have less infection, less cell death, and therefore less nucleocapsid antibodies. So if you take that one step further and you take patients who haven't been infected but who have received the vaccine, they're going to have no nucleocapsid antibodies and instead have only spike antibodies.
Great, thank you. So I thought I would turn at the end to some really hard questions, maybe throw it to Dr. Prutzman first. This was a question that was from the audience, but I think it kind of speaks to the heart of it. So they asked, what about why are we talking about efficacy of vaccination while a big proportion of the world population will not be vaccinated for years? So it's kind of a hard question. And I think it does get to sort of equitable rollout of the vaccines. And I'm sort of curious from I'm not sure what the FDA, if they even have a position on this. So I do open it up to everyone to just talk about different ways that we can approach equity with vaccine distribution.
So, I guess I'll start. This is a little bit outside the FDA's purview. We're really charged with ensuring that the vaccines are safe and effective when they're rolled out, and then studies to monitor safety after they're licensed or authorized. But I will say that part of answering that or getting at that solution is that you want to have the most vaccines and most vaccine doses available, and we're trying to create a very transparent pathway. And I hope, it's as fast as we can go with being responsible at allowing vaccines to be authorized. In this case, they're authorized, not licensed. The best we can do is make the pathway as easy to follow as possible. And we're encouraging people to come in and talk to us as much as possible. And working around the clock, I think there's another vaccine that's being reviewed right now that's in the news. You can read about it. Hopefully we'll have a third vaccine available. And if you read the news, there's plenty others that are coming down the pike as well. So I think from our perspective, the best role we can play is making the more doses available for everyone.
This is Eyal. Perhaps I can add a more programmatic side of the question, and that is that there are global organizations such as Gavi and the World Health Organization that are making an attempt to move forward with preparing the cold chains and the logistics to vaccinate as to cover as many in the world population, the global population as possible. And this will be made possible by approving vaccines that do not mandate deep freeze, such as the Pfizer vaccine, which is not feasible in many countries that will not be able to logistically support such an immunization program. So other vaccines with a more feasible logistics will enable global coverage. And with organizations such as Gavi, and UNICEF and other organizations working towards global immunization, we know the last decade has seen several new vaccines introduced in these poorest nations, such as rotavirus, such as pneumococcal vaccine, meningococcal vaccine in Africa, and other vaccines. So we do think COVID vaccines will be introduced also to the poorer nations.
Thank you. I think that's incredibly important. One of the concerns I always have myself as a vaccine scientist and researcher is that you create vaccines that really don't get to the most vulnerable populations, and especially when now we don't have proof for sure that these vaccines prevent transmission to others, though I think almost everyone believes they certainly do to some extent. So the idea that you would have certain regions where you might develop herd immunity and other regions that completely have accelerated pandemics is very disturbing to think about. I guess I can ask the question, since we have an educated group of speakers here, what are your opinions about your best guess about whether these vaccines prevent transmission to other people? What do you guys think?
Eyal, again, I can offer some perspective from what we're seeing in Israel, and some of these ecologic data that I shared in my presentation certainly shows that there is a reduction in both infection and transmission. We are starting to collect data on the CT values of those immunized that are infected, and we are definitely seeing higher CT values in persons who received partial or full course of the vaccine compared with unvaccinated infected. So this is also a surrogate to lower transmissibility. And I think these data will gather quickly, because there are some large data sets of both epidemiologic and lab data sets on immunized populations that will be published in the next weeks or months to answer at least partially this question.
What about the rest of you?
I think I'd echo that sentiment that if you look at even the data from some of the supplemental data from the FDA filings on the number of symptomatic versus asymptomatic infections in the vaccine and the placebo groups, the evidence looks like there's going to be a reduction in transmission. It's obviously nothing in science is absolute, but it's really promising data, and I look forward to seeing more of it, as was alluded to.
Yeah, and I would concur with a lot of this. What I would say from what I've seen at the FDA is that generally things don't happen in a vacuum. So when you have good efficacy in one aspect of a vaccine, usually you have effects all around the board. So we don't have a lot of data right now, for example, on severe COVID, but all of it looks good so far. And I would have been surprised, even if we didn't have any data, that it wouldn't have a good effect on severe COVID. And on the other end, I'd be surprised if it also didn't have an effect on asymptomatic and therefore transmission.
Dr. Venter, what do you think? You've been very quiet. François, hello.
Sorry, I was looking for the wrong button. I think that I agree. I think that the chance that there's no impact on transmission seems to be very, very unlikely. I think we're obviously having the South African variant in the eye of the storm, watching all of this very keenly. I'm very pleased to report to the audience we just had our first batch of J&J vaccine just land in the last 10 minutes. So we're thrilled to be amongst the first countries in Africa to start rolling out the vaccine. But I think the issues of vaccine nationalism and how do we do this equitably and get the whole globe vaccinated as quickly as possible is probably something everybody in the audience is going to need to start focusing on going forward.
So looking towards the future, we've talked all the vaccines that are out there now and in the short-term pipeline are all focused on the spike protein, even though the platforms may be different. But there was a question from the audience just now about any future kind of game changer vaccines, and I'm just wondering if any of you guys have anything in your pipeline that you're thinking about, maybe focus on T cells or something else that might be a game changer.
I think that the T cell aspect of this is really important and really promising for the long-term memory, and perhaps not completely eliminating future outbreaks, but certainly mitigating them. And so, I think understanding the role that T cells play in combating some of these variants is something that would be important to understand, and I'm sure is undergoing right now. The great thing about this time is that just about every week there's 3 or 4 really nice papers that come out that expand our understanding on this virus, and it's really reflective of the global community being able to come together and really tackle this huge problem.
Thank you. I agree about the papers, though. It's almost impossible to keep up with them, of course. Well, I've gotten all these questions from the audience. Do you guys have any further questions for each other? Okay, all right. So I think what I'll do is I will wrap up. I think we've heard a lot about the variants today, and we're all very excited about the vaccines, but I think it's just to remind everybody in the audience that the variants tell us that we need to keep wearing our masks. So what we need are multiple layers of protection, multiple mitigation strategies, and no matter how good our vaccines are, there will be ways to break through them. So it's a large audience, very international, so don't forget to wear your masks, especially with the new variants circulating. A couple other points. One is that at the end of this, there's going to be a survey that goes out to everyone to talk about how they enjoyed the talks today. So everybody please fill those out if you can. And then this whole workshop and conference is going on again tomorrow. So we would please hope that everyone joins us again. That's starting at 6 p.m. European time and 12 p.m. here Eastern time. So I think that pretty much comes to the end for us. I don't know if anyone has any closing remarks that they would like to share with the audience. All right. I think then we'll close it up for today. And I just want to speak on behalf of François Venter and the rest of the organizing committee as well. Our deep appreciation for all of our speakers today and for the audience's great questions. Thank you.